Slightly older child, 14-year-old, referred to us for multiple episodes of vomiting since the past 6 years. Vomiting would start classically in the morning on waking, but not necessarily so. There used to be a prodrome of nausea, abdominal pain, retching, severe unrelenting vomiting every 5 to 10 minutes, almost going on 20 to 30 episodes per day. Occasionally bilious also, occasionally hematemesis, some of the episodes. Quite often requiring hospital admission because the child used to get dehydrated even though she was 14-year-old. In this girl, the episodes quite commonly used to occur around the time of menses, very little response to antiemetics, would last for 48 to 72 hours, rapid recovery, and child used to be normal completely between the episodes. She required many admissions, and obviously because of the problems, many doctors. History, nothing very significant. Clinically, examination would be completely normal. Some doctors had made a diagnosis of chronic appendicitis. 6 months prior to coming to us, she had been diagnosed as a superior mesenteric artery syndrome. She had in fact undergone surgery. Duodenojejunectomy was done. She was okay for 2 months. Parent thought problems are over. Unfortunately, things started all over again. In this particular child, I would like to ask, how would you investigate this particular child further, or how would you investigate this older child with recurrent vomiting? Could you ask Sandhya that question?
Thanks. So this is the difference of a chronic vomiting disorder to something that is a sort of more cyclical pattern. I still think it's important to rule out anatomical problems, because malrotation can present at a later age. There have been numerous presentations of 44-year-olds up to teenage years. So a baseline barium swallow, just to ensure that there is no stricture, and it will also tell you whether there's any other reasons that could be causing this, such as a developing achalasia, a stricture, or to exclude that. However, one also then nice to think about the not necessarily GI causes. So migraine can present in this way. Some people call it straightforward migraine, some people call it abdominal migraine, but it presents in a similar fashion. One also needs to start thinking about whether this is part of a metabolic type problem, which again can present at a later age group, and whether there is we have our vomiting centre in the brain, and so one needs to ensure that there's no CNS reasons for it. And bearing in mind these is the pattern of investigations that I would follow. So I'd start off by excluding the GI causes, do the bear and follow, depending on the amount of weight loss. If there's been no weight loss, and there's in a 14-year-old, if she's not complaining of dysphagia or choking episodes, achalasias and strictures are unlikely. If she's well and thriving, then it's more likely to be either just a motility disorder or a migraine type picture. One can also just, again, empirically consider doing a trial of anti-migraine treatment. If it's been persisting or there's additional symptoms again, such as weight loss, one needs to consider whether you go forward and do an MRI of the brain, because there is a condition called cyclical vomiting, classically presented in the teenage group, more predominantly females, and they have severe vomiting that lasts a few days. They become quite dehydrated, often requiring IV fluids, and this is a diagnosis of exclusion. So these patients really, before being labelled cyclical vomiters, shouldn't have a normal MRI, normal workup.
So the point to make over here is, when you have this sort of a recurrent vomiting, clinically you would try to differentiate it between the chronic and the cyclic. The only reason is for your approach. Chronic low-grade vomiting every day going on is more likely to be GI than non-GI, while cyclical vomiting, which occurs in an episode and the child is well between that, is more likely to be extra GI than GI. And so if you're doing all the investigations towards the GI system, it's quite likely you may not pick up anything there. Any further investigations, Ujjal, in this particular?
Ashish, before investigation, I have to make it clear. if you make a diagnosis of cyclical vomiting is a clinical diagnosis. No investigation can give you a proof that this is cyclical vomiting.
No, I'm not saying
so
cyclical
history,
vomiting syndrome.
Let me
I'm not talking
clarify.
about CVS. I'm talking about cyclical vomiting as a presentation of vomiting.
I agree. So this child, one point you have not highlighted, the intensity of the vomiting. That is very important. I think we are finishing the time. Cyclical vomiting, if you think, cyclical vomiting syndrome, the 2 point is important historically. One is the intensity of the vomiting. How severe is the vomiting? It has to be at least 4 bouts of vomiting per hour to think about cyclical vomiting syndrome, and period of wellness, at least 1 week apart, these episodes. Then you seriously think about cyclical vomiting syndrome, and then think about whether there is any other reason to believe that this is not true cyclical vomiting, there is organic cause. If you don't have any alarm symptom for suppose bilious vomiting for GI or metabolic cause or neurological, like no neurological, no papilledema, then there is nothing called ruling out. If you think about the disease which can cause cyclical vomiting, there is no end. You start from MRI, CT scan, what not, everything you can do. Still you will not get the answer. First you make up your mind. Is it cyclical vomiting syndrome? Yes. Then only investigation recommended is barium study to rule out any anatomical obstruction. Nothing else. And then you go for treatment.
You are what I'm trying to say is we are not talking about the syndrome as such. I'm talking about a child who presents with periodic cyclical vomiting. What are the conditions that you need to think of, which you would investigate? After investigations, you find there's nothing coming up. You think about the entity called as cyclical vomiting syndrome.
Here my objection. My objection is that if you are handling a child of cyclical vomiting syndrome and you want to rule out neurological cause, you want to rule out metabolic cause, you want to rule out GI cause, if you are in a private practice, if you have a facility of cutback, then you are wiser. But if you are in a good practicing doctor who wants to make a right diagnosis, then I will not subscribe to this concept of ruling out all condition to label a cyclical vomiting syndrome.
Have there been cases reported of cyclical, so-called liberal cyclical vomiting syndrome turning out to be any of the metabolic causes especially?
Yes, possible. See, the clinical diagnosis, your accuracy is somewhere around 70 to 80%. That doesn't mean that you have to investigate each and every cases.
Right. So you would, in this particular child which you talked about, you would say no investigations? The one that we're talking about here?
Simple investigation is recommended. You do the metabolic screen. Doing
Right.
electrolytes, blood sugar is not going to cost.
Right.
But doing MRI each and every patient with cyclical vomiting is not justified. It is unethical practice.
That's fine. Okay. The question. Can we just finish it, sir? It's already late. We can do the discussion. Is it time? This child had already had a surgical opinion, obviously, and has undergone surgery. In this particular child, is there any role of any other surgical opinion?
You
At
are
this
asking
stage?
me?
No, I'm asking the surgeons. Because
It is up to the physicians to take surgical opinion. So how can you ask me this question?
No, do you think?
Is it time for another surgical opinion? So the patient is with the physician. He or she has to refer the patient to me.
Would
So you better ask him.
In your position, would you like the physician to now send this child back to you with an opinion?
Well, basically as a surgeon, I would certainly, if enough investigations haven't been carried out to rule out a pathological, surgical pathology, then I would definitely like to further investigate, and the best investigation would be CT.
Okay. So you would like
Because there are cases like, we have come across cases where there is internal herniation, mesocolic hernias, which are not obviously apparent in routine barium study.
Right. A couple of things for you also. These are two of the entities which are quite commonly, when you refer a child to a surgeon, one of the diagnoses given is chronic appendicitis. I would like to know if this term really exists and what does it mean. And also the superior mesenteric artery syndrome. I mean, do they have any medical, surgical?
How much time do we have?
Okay, after this question we'll stop. Sure. So we'll ask the last question.
So shall I answer the question?
Yeah.
Well, very briefly, superior mesenteric artery syndrome is that the third part of the duodenum, which is the horizontal part, gets compressed between the aorta behind and the superior mesenteric artery in front. Normally there's an angle of about 45 degrees of the superior mesenteric artery with the aorta. So there's enough room for the third part of duodenum to be situated between the two. But because of some reason, which may be anatomical, like low arising of the superior mesenteric artery, or there's a severe lordosis which pushes the aorta in front, something like this, or a high ligament of Treats, or sometimes is acute weight loss because of whatever problem, and that diminishes the mesenteric fat, and the angle between the superior mesenteric artery and the aorta becomes much smaller, narrower, pressing on the third part of duodenum. So in such a case, that's the superior mesenteric artery syndrome in short, and that can be documented either in barium, which shows a huge dilatation of the duodenum and an abrupt cutout where the superior mesenteric artery is pressing on the third part of duodenum. If this is not evident, then ultrasound or even CT scan can actually give you the distance between the two vessels and the angle. And first of all, you should try, if it is because of weight loss, then of course you try to give enteral feeds or coupled with parenteral nutrition, and then if it doesn't respond, then only surgery is the option. But not
The reason for asking that question is that there are a lot of cases reported, and we also see mentioned as superior mesenteric artery syndrome, which have thought to be the cause of vomiting, but ultimately has been shown that it's just not the cause of vomiting.
No,
it's just
I won't
there.
take the radiological diagnosis.
Okay. And concept of chronic appendicitis, does that work? Because
It's a
that's
big
something-
controversy.
Okay.
So since the time is not enough,
Sure,
I don't
we'll
think.
not go into that. Okay, I think we will stop the things here.